Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based review of otitis externa in children, designed for general pediatricians. Otitis externa, also known as swimmer's ear, is an inflammatory condition of the external auditory canal that is especially common in school-aged children, athletes, and during warm, humid months. Throughout this lecture, we will work through 10 carefully designed clinical cases covering pathophysiology, clinical presentation, otoscopic findings, severity grading, first-line therapy, management with tympanic membrane perforation, treatment failure, the immunocompromised patient, otomycosis, and advanced management with earwigs and prevention. By the end, you will have a structured framework to confidently diagnose and manage otitis externa in everyday pediatric practice. Let us begin. Case 1. An 8-year-old competitive swimmer presents with progressive severe left ear pain of 2 days duration. Which of the following best describes the initial pathophysiological step in the development of this condition? Option A. Eustachian tube dysfunction leading to middle ear effusion. Option B. Hematogenous seeding of the external auditory canal skin. Option C. Moisture-induced maceration of skin and loss of acidic cerumen barrier. Option D. Primary fungal colonization of the tympanic membrane. The correct answer is option C. Moisture-induced maceration of skin and loss of the acidic cerumen barrier. Cerumen plays a vital protective role by providing an acidic pH of 6.1 to 6.5 and a hydrophobic lipid barrier that shields the ear canal from microbial invasion. Prolonged moisture exposure, especially from swimming or humid environments, disrupts this barrier, macerates the stratum corneum, and raises the canal pH above 7. This alkaline, waterlogged environment is ideal for bacterial overgrowth and invasion. The two primary pathogens are Pseudomonas aeruginosa and Staphylococcus aureus. This is why otitis externa is fundamentally a disease of the skin and not of the middle ear, and why prevention strategies focus on keeping the canal dry and acidic. Case 2. A 6-year-old girl is brought in with severe right ear pain. She cries when her mother brushes her hair near the ear or when she lies down on her right side. Which physical exam maneuver is most specific for diagnosing acute otitis externa in this patient? Option A. Pain elicited by manipulation of the auricle or tragus. Option B. Tenderness to palpation over the mastoid process. Option C. Absence of the light reflex on otoscopy. Option D. Eliciting pain with pneumatic otoscopy. The correct answer is option A. Pain elicited by manipulation of the auricle or tragus. Tragal and auricular tenderness is the hallmark of acute otitis externa and is present in over 95% of cases. The tragus sign is elicited by gentle pressure on the tragus, while the pinna sign is elicited by gentle upward traction on the auricle. Both maneuvers reproduce the characteristic pain because the skin of the cartilaginous canal is tightly bound to a highly sensitive periosteum, which becomes inflamed during infection. In contrast, mastoid tenderness suggests mastoiditis, and a dull or immobile tympanic membrane suggests otitis media. Remember the practical clue: a child who cries when you simply touch the outer ear almost always has otitis externa. Case 3. A 10-year-old boy presents with ear fullness and mild hearing loss. Otoscopy reveals a swollen canal filled with thick, yellowish-white debris. What is the status of the tympanic membrane in uncomplicated acute otitis externa? Option A. Bulging, erythematous, and immobile. Option B. Perforated with active pulsatile middle ear discharge. Option C. Retracted with a fluid light level behind it. Option D. Normal and mobile, though sometimes mildly erythematous. The correct answer is option D. Normal and mobile, though sometimes mildly erythematous. In uncomplicated acute otitis externa, the disease is confined to the external auditory canal, so the tympanic membrane itself remains normal in position and mobility. Mild erythema may occur from adjacent inflammation, but bulging or impaired mobility points instead to acute otitis media. Visualizing the tympanic membrane is critical to rule out concurrent otitis media or a perforation, because both change the management approach significantly. If the canal is so swollen that the tympanic membrane cannot be visualized, the patient must be managed cautiously and assumed to potentially have a perforation until proven otherwise. Key differentiating features include an edematous and erythematous canal with debris in otitis externa compared to a normal canal but abnormal tympanic membrane in otitis media. Case 4. A 12-year-old female presents with severe ear pain, complete occlusion of the external auditory canal due to swelling, and periauricular erythema. How is the clinical severity of this patient's acute otitis externa classified? Option A. Mild. Option B. Severe. Option C. Moderate. Option D. Complicated. The correct answer is option B. Severe. Severity grading of acute otitis externa is based on three findings: the degree of pain, the extent of canal occlusion, and the presence of regional or systemic signs. Mild disease shows minor pain or itching with less than 25% canal occlusion. Moderate disease shows intermediate pain with 25 to 75% occlusion and debris in a partially patent canal. Severe disease is characterized by intense pain, complete or greater than 75% canal occlusion, and often preauricular or regional lymphadenopathy. Severe cases frequently require the placement of an ear wick to facilitate drop delivery because topical medication cannot reach the inflamed tissue through a closed canal. Accurate grading directly guides the choice of topical agents and the need for adjuvant therapies. Case 5. A 7-year-old child is diagnosed with moderate, uncomplicated acute otitis externa of the left ear. The tympanic membrane is fully visible and intact. What is the recommended first-line treatment for this patient? Option A, topical antibiotic glucocorticoid ear drops. Option B, oral amoxicillin clavulanate for 10 days. Option C, topical alcohol acetic acid drops. Option D, oral ciprofloxacin for 7 days. The correct answer is option A, topical antibiotic glucocorticoid eardrops. Topical therapy is the cornerstone of treatment for uncomplicated acute otitis externa. Topical preparations deliver extremely high local drug concentrations, approximately 100 to 1000 times higher than systemic therapy could ever achieve, with virtually no systemic absorption or side effects. Combination drops containing an antibiotic such as ciprofloxacin paired with a steroid such as dexamethasone resolve pain and inflammation faster than antibiotics alone. Systemic antibiotics are not indicated for uncomplicated otitis externa because they offer no benefit, increase antimicrobial resistance, and expose the child to unnecessary side effects. Reserve systemic therapy for cases with cellulitis extending beyond the canal, immunocompromised hosts, or suspected malignant otitis externa. Case 6. A 9-year-old girl with a history of tympanostomy tubes presents with left ear canal swelling and discharge. The tube is visible and patent. Which topical preparation is safest and most appropriate for this patient? Option A, neomycin, polymyxin B, and hydrocortisone drops. Option B, gentamicin ophthalmic drops. Option C, ciprofloxacin and dexamethasone drops. Option D, acetic acid 2% otic solution. The correct answer is option C, ciprofloxacin and dexamethasone drops. Whenever the tympanic membrane is perforated or a tympanostomy tube is in place, the topical medication can enter the middle ear and reach the cochlear and vestibular system. Aminoglycosides such as neomycin and gentamicin are cochleotoxic and vestibulotoxic if they reach the middle ear, and can cause permanent sensorineural hearing loss or balance problems. Acidifying agents such as acetic acid cause severe pain and chemical irritation to the middle ear mucosa and should also be avoided. Fluoroquinolones, specifically ciprofloxacin and ofloxacin, are non-ototoxic and are the only topical agents proven safe to use when there is a perforation or a patent tympanostomy tube. The key clinical rule is simple: when the membrane is not intact, only fluoroquinolone drops are safe. Case 7. A 5-year-old boy has been treated with ciprofloxacin and dexamethasone drops for 6 days for suspected acute otitis externa, but his ear pain and canal swelling have worsened. What is the most appropriate next diagnostic step? Option A, perform an urgent computed tomography scan of the temporal bone. Option B, obtain a complete blood count and erythrocyte sedimentation rate. Option C, refer immediately for surgical debridement. Option D, obtain a culture of the external auditory canal debris. The correct answer is option D, obtain a culture of the external auditory canal debris. Routine cultures are not recommended for uncomplicated initial presentations of acute otitis externa because empirical topical therapy reliably covers the usual pathogens. However, when treatment fails after 48 to 72 hours of appropriate therapy, cultures become essential to guide further management. Cultures are specifically indicated for treatment failure, atypical pathogens, immunocompromised hosts, or suspected fungal infection. They help identify resistant bacteria such as methicillin-resistant Staphylococcus aureus or fungal infections such as otomycosis, both of which require completely different therapy. Imaging and surgical referral are reserved for suspected complications such as malignant otitis externa or deep tissue extension, not for routine treatment failure. Case 8. A 14-year-old boy with poorly controlled type 1 diabetes presents with excruciating deep-seated left ear pain, fever, and a drooping left side of his mouth. What is the most likely diagnosis and immediate management? Option A, uncomplicated acute otitis externa, increase frequency of topical drops. Option B, Malignant, also known as necrotizing, otitis externa, urgent intravenous antibiotics and imaging. Option C, automycosis, topical clotrimazole drops. Option D, Ramsay-Hunt syndrome, oral acyclovir and